I'm not going to do a case in the interest of time, but obviously key take-home messages and thinking about red flags, but I've dropped the examination part. Next slide, please. So as we know, and you've heard this afternoon, all colleagues in the room will see dizziness frequently in primary care. It's a common symptom, sometimes as a primary presentation, sometimes as part of a constellation of symptoms that a patient presents with. And most of the time, dizziness is benign. So it's not something that merits further investigation or referral. It's something that, as ever in medicine with a decent history, you can establish the cause, and it tends to be self-limiting and something that we can manage in primary care. I suppose the exception to that would be particular types of strokes, posterior circulation stroke in particular, that can present with an isolated vertigo. And obviously, as with any acute, potentially life-threatening diagnosis, it's really important to try to identify those patients. Next slide, please. So again, I often do this, and again, I'm sure most colleagues do this. When patients talk about dizziness, I ask them to explain exactly what they mean, because as we all know, that's a word that means different things to different people. So asking them to just explain subjectively exactly what it is they're experiencing is important in terms of making a diagnosis. So I sometimes talk to patients about, when they say dizziness, are they experiencing movement within the room, even when they are sitting still, standing still, whatever, as opposed to a sensation of feeling a bit unsteady, like they're on a ship. And so getting that sort of distinction is important between true vertigo or pre-syncope or just feeling a bit unsteady. Next slide, please. So in terms of diagnosis, I think it's helpful to think about central versus peripheral causes of vertigo. Peripheral causes would be benign positional vertigo, vestibular neuritis, Meniere's disease. Central causes would be thinking about the cerebellum, about potentially a space-occupying lesion. And central causes often lack hearing symptoms, unlike, say, in Meniere's disease, where you have typically hearing loss, tinnitus, and balance problems. And neurological signs are the key discriminating factor. Next slide, please. So thinking about stroke or TIA is the key, I suppose, acute diagnosis not to miss. That would be the commonest neurological cause. And in terms of, sometimes it can be subtle. If you've got a patient who comes in and the only symptom they've got is dizziness, then it's just thinking about it's being alert to risk factors, so obviously age, history, comorbidities, and so on. And again, that might be the only symptom a person presents with. Red flags would be these other signs, which again can be confusing because, or there's a bit of a red herring there, because someone with a headache with dizziness, that could be a relatively benign cause. It wouldn't necessarily be a sinister cause, but certainly anything like ataxia, diplopia, dysarthria, these would be red flags, and we would refer accordingly. Next slide, please. So what kind of cerebellar pathology? We're talking about stroke, bleed, tumours. You would see perhaps severe gait ataxia, which would be out of proportion to what you would expect in someone with more benign vertigo. Changes that you would see in terms of nystagmus and vomiting and headache. But again, it's difficult because some patients with acute migraine will manifest with all of these symptoms: vomiting, headache, and potentially balance problems. Next slide, please. MS is another differential diagnosis caused by demyelination. You might see someone presenting with vertigo where the underlying diagnosis is MS. It's not typical, but again, you would think about the particular demographic. It would be something you would see with younger adults, and try and look for other factors in the history that might fit with the diagnosis of MS. Next. This is probably one of the most common causes, I would say, in terms of a neurological cause of dizziness. Migraine is extremely common. About 1 in 7 people globally suffer from migraine. So that's 1 billion people. In the UK, 10 million people. There's different statistics when you read online, but the proportion of people with migraine who have vestibular migraine ranges from 10 up to 25%. So that's a lot of patients. One of the neurologists that we work with in our team, she deals with 2-week wait referrals to secondary care for potential CNS cancers, and she says that about 30% of the referrals actually turn out to be migraine. And it's a challenge, right, when you're sitting in primary care to make sure that we're not missing serious diagnosis. So what would you expect to see with vestibular migraine? It would be a lot of the typical symptoms that we would see: recurrent vertigo associated with headache, visual disturbance, that sensitivity patients describe in terms of, I want to lie down in a dark room, doctor. You know, that's how they feel when they get the symptoms. And it's a diagnosis of exclusion. Next slide, please. So red flags would be a new focal neurological deficit, a sort of severe gait imbalance as opposed to I feel slightly unsteady. Perhaps in an older patient, an acute onset. So again, you're thinking about people's cardiovascular risk factors. It's much less likely to be a stroke in someone who's 30 and relatively fit, as opposed to a male patient with risk factors in their 60s. And obviously you can sometimes see, though not always, this nystagmus, which would perhaps raise a flag in terms of concerns about something more serious going on. Next slide, please. So in terms of the examination, again, these are things that colleagues will be doing. Watch the way the patient walks into the consulting room, thinking about eye movements, coordination, speech, and then also thinking about blood pressure and pulse. So again, that sort of focused neurological examination that you can do realistically in a 10-minute consultation. In terms of when to refer, obviously if you're concerned about an acute event, then it's an emergency. I would say anyone with persistent or progressive symptoms, so obviously in a spatial occupying lesion you're much more likely to have those kinds of symptoms as opposed to someone who's having episodic symptoms, which would be consistent more with migraine. Any red flags, and an MRI brain is preferred for central causes. I often think it's challenging sitting in primary care, when we speak to colleagues in secondary care and they say, oh well, we pick up 30% of the cases in the 2-week wait clinic are migraine. But that's of course when you're sitting in a clinic with all these imaging modalities on hand and a whole series of investigations. When you're on your own in your consulting room, you have to make a judgment call without access to all of that. So it's the careful history and examination, but if in doubt, obviously refer. I much prefer to refer patients that I'm worried about and then receive a letter back to say, actually it was fine, this is just migraine, than send someone home with migraine treatment who actually turns out to have a much more serious diagnosis. Next one. So really the key messages from a neurological perspective in terms of dizziness are people can present with simply vertigo symptoms when there is a stroke. Think about gait, think about eye signs, and if in doubt, refer. Thank you.